Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to The Deep Dive. Today, we're opening up a stack of foundational sources on a framework that is really the backbone of safe acute surgical practice.
We're talking about the care of the critically ill surgical patient, or, as everyone knows it, the CCrISP protocol.
And our mission today isn't just to, list the steps. For our audience, for the surgical professional, we want to extract the deep structure.
Exactly. The why behind it. The clinical thinking that lets you move from just observing to, well, definitive life-saving action when your patient starts to crash.
It's about getting to that point where the system is just second nature, so it reduces your cognitive load when things are getting stressful.
Which they always do.
Yeah, but before we get into the framework itself, we absolutely have to start with the essential clinical disclaimer.
That's critical. This content is for professional reference only. Always, and I mean always, adhere to your specific local protocols, your national guidelines, and of course the clinical needs of the actual patient in front of you.
Duly noted. Okay, so let's set the historical context because it really tells you why this was so necessary.
It's a powerful story. CCrISP came from the Royal College of Surgeons of England, and it was a direct result of the 1989 Hillsborough disaster.
Right. There was a clear need for a systematic, non-trauma approach to crisis management in that acute surgical setting.
And since it was formally introduced back in 1998, it's gone through, 4 editions? It's become a universal standard.
It has.
You know, the incredible thing about CCrISP is that its philosophy is so simple, you could almost miss it.
What's that?
Prompt, simple actions save lives and prevent complications. That's it. It just forces you into a proactive mindset.
It ensures you don't overlook a simple fix while you're distracted by some complex diagnostic puzzle.
That's the real genius of it. And I think that's what distinguishes it. It's not just a checklist.
No, it demands simultaneous assessment and
an active resuscitation. You're doing both at the same time.
Exactly. You're on parallel tracks.
Now,
this whole systematic approach is designed specifically to stop you from making those critical omissions,
which we know are the silent killers in these high-pressure situations.
And the cornerstone of that whole structure is, of course, the hierarchical ABCDE assessment framework.
Absolutely. And for anyone listening, the beauty is its universality. It doesn't matter if it's a deteriorating ward patient, a new acute admission, or a post-op complication. The approach is always the same.
Okay, let's dive right into that framework, starting with A for airway. Now, beyond just checking for patency, what are the specific pitfalls for a surgical patient, especially post-op?
That's a great question, because it's not just, altered consciousness from anesthesia. You have to think mechanically.
Carries narration risk?
A huge one, often made worse by an ileus or retained stomach contents. And then you have to look for actual physical obstruction.
Like from swelling.
Post-surgical edema, inflammatory swelling.
Yeah.
Maybe after a big head and neck case or a deep neck space infection. And the protocol is very clear here.
If the simple things don't work.
Right. If positioning or suction isn't enough to secure it, you escalate immediately. For most of us, that means an urgent call to our anesthetic colleagues and getting ready for intubation.
Makes sense. Failure in A is almost always catastrophic. So moving on to B, breathing.
Right. So you're looking at the basics, rate, pattern, O2 sats, the work of breathing.
But for an advanced audience, we have to talk about the arterial blood gas, the ABG.
Oh, absolutely. The ABG is essential. It's how you distinguish between just, say, hypoxemic failure and failure that also involves hypercapnia arising CA2.
And hypercapnia post-op points you towards a few specific things.
It does. Often it's opiate-induced respiratory depression. That's a quick fix you find under D. But it can also mean profound muscle fatigue or something serious like ARDS.
And in a surgical context, you always have to be thinking about the big scary things, a massive PE
or a tension pneumothorax, the most urgent one.
And this is where the CCrISP framework really shines, right? It mandates the simple action before the complex diagnosis.
Precisely. If that patient is crashing and you suspect a tension pneumothorax, you decompress them. You do the needle thoracocentesis right then and there. You don't wait for a chest x-ray. It's action embedded in assessment.
Perfect. So now we're at C circulation, and here we are mostly talking about shock, hypoperfusion.
That's the main life threat. You're measuring the usual things: heart rate, blood pressure, urine output, mental status. But the real clinical pearl here is to focus on peripheral perfusion.
Cap refill, skin temperature.
Yes. That peripheral assessment can show you a failing cardiac output long before the central blood pressure starts to drop.
So the moment you see signs of hyperperfusion, the clock starts. You're getting large bore, IV, access gray, or orange cannulae.
Immediately. And your fluid choice has to be just as fast and rational. Blood for bleeding, crystalloids for everything else.
Let's dig into septic shock specifically, because the targets here can get complex.
The protocol is rigid here for a very good reason. Antibiotics within 1 hour of recognition. Period. Fluid resuscitation starts with a bolus, usually 500 milliliter of crystalloid over less than 15 minutes.
But this is where some nuance comes in. The traditional framework might talk about static CVP targets, say 8 to 12.
Right, but contemporary critical care has sort of moved beyond that. We're now much more focused on functional hemodynamic monitoring.
That's the key insight. So while we're following the structure, we're layering modern knowledge on top. We're looking for signs of fluid responsiveness.
Exactly. Using things like bedside ultrasound or pulse pressure variation, rather than just relying on a single CVP number, which, can be really unreliable.
And if the MAP is still below 65, despite good fluid management,
You transition straight to vasopressors. Norepinephrine is the first choice. And you keep measuring lactate. That's your ongoing guide to see if your resuscitation is actually working.
that systematic approach is what saves time. Okay, D, disability, a rapid neuroassessment, GCS, pupils.
This is a tough one post-operatively. The picture is always clouded by pain medication, residual anesthetic.
It is?
But this step forces you to look past that haze and find the reversible causes. Is the patient just oversedated? Do they need naloxone?
Or have they become hypoglycemic? Is it a metabolic issue like severe hyponatremia?
Exactly. You diagnose and treat those reversible causes before you assume it's a major intracranial event. You also have to, keep an eye out for signs of rising intracranial pressure. It's rare in general surgery, but you can't miss it.
And that brings us to the final step in the immediate phase, E for exposure. It's so easily dismissed, but it's non-negotiable.
Oh, it's a classic pitfall. When you're under stress, you focus on the main problem, the surgical wound. CCrISP forces you to do a full head-to-toe examination.
You literally have to strip the patient.
You have to find what you've missed. Is there a bleed from an old IV site, a rash that points to a drug reaction or a different septic source? And critically, you have to check every drain, every wound. You just can't afford to miss a subtle sign because it was hidden under a blanket.
Okay, so we've fought the initial fire. We've used ABCDE to stabilize the immediate threats. But the protocol doesn't stop there.
No, that's the crucial transition. ABCDE is the beginning, not the end. Once the immediate threats are managed, even if the patient is only temporarily stable, you move to the second layer.
The full patient assessment.
This is where you go from firefighter to detective. You start integrating all the history and context.
And that means methodically reviewing everything. Case notes, meds, comorbidities.
Right. Does the patient have chronic kidney disease, severe heart failure? You integrate every lab result, every imaging study to build a proper differential diagnosis. This is what you need for definitive planning.
And that comprehensive assessment then leads you down a clear decision pathway.
Exactly. If the patient's stable and the diagnosis is clear, you proceed. If they're still unstable or the cause isn't obvious, you need urgent, targeted diagnostics, cultures, a CT scan, whatever it takes.
So the treatment becomes definitive medical, surgical, or even radiological. And now we get to what I think is the aha moment. The critical rule that really defines the brilliance of CCrISP and protects us from fixation bias.
Return loop.
At any point, if that patient deteriorates again, even slightly, you wipe the slate clean and go straight back to A.
It's the core safety mechanism. It prevents that tunnel vision where you're so focused on your initial diagnosis of, say, pneumonia, that you miss the fact the patient just developed a tension pneumothorax. It forces continuous reassessment.
Let's apply this to a few high-stakes scenarios. First up, septic shock. We've talked about antibiotics, but CCrISP's real value here is forcing the issue on surgical source control.
Absolutely. The protocol ensures that once you've made the diagnosis, a senior surgeon is leading the plan for source control, draining an abscess, resecting dead bowel, a washout, whatever is needed.
Because without source control.
Antibiotics and vasopressors are often just a temporary fix. They're futile in the long run.
Okay, next scenario, postoperative acute kidney injury, or AKI. A massive problem. Complicates up to 40% of major abdominal cases.
And CCrISP frames AKI as what it usually is, a sign of inadequate renal perfusion. It's because of hypovolemia, sepsis, or shock.
So the intervention it mandates is all about fluid optimization.
And it speaks directly to that modern clinical debate.
Yeah.
You're trying to avoid both pitfalls under resuscitation and over resuscitation. Too little fluid causes hypovolemia, but too much causes tissue edema and also worsens AKI.
So if hypotension persists despite careful fluid management, the systematic next step is vasopressors.
To maintain that perfusion pressure for the kidneys, yes.
Let's talk about postoperative hemorrhage. I mean, this is maybe the fastest way a surgical patient can die. The psychological pressure is immense.
It is, because you're trying to do two things at once. Massive transfusion and diagnosis. The protocol just streamlines that chaos.
So ABCDE starts, secure A and B, get massive bore IVs or central access.
Activate the massive transfusion protocol, and at the same time, you're urgently contacting the operating theater and your senior colleagues.
And the decision tree is clear.
Very clear. If a drain is pouring out blood, that patient needs to be explored immediately. If you suspect an intra-abdominal bleed-new pain, peritonism, you don't wait. You take them back to the operating room. Delay kills.
And just to circle back to B for a moment, pulmonary complications, pneumonia, PC, ARDS, they're endemic post-op.
And by mandating that early ABG, the protocol gives you the framework to figure it out. You can distinguish the hypercapnia of opiate overdoses, which is easy to reverse, from pure hypoxemia, which points to a more serious lung problem.
And the actions just flow logically from there. Titrated oxygen, nebulizers, early antibiotics if infection is likely.
It all connects.
You know, if we pull back from the individual steps, CCrISP, it's really about creating a whole culture of safety.
Absolutely. It heavily emphasizes the multidisciplinary care framework. Managing these patients well is a team sport. It requires collaborative fluency between surgeons, nurses, anesthetists, intensivists, everyone.
So communication becomes paramount.
It does. A surgeon has to clearly articulate their ABCDE assessment and their plan to the whole team. And, crucially, they have to involve senior colleagues early.
Before the situation is irretrievable.
Yes. That structured communication is what prevents errors and ensures timely escalation. And the course itself is designed to build those behaviors. It's all high-fidelity, scenario-based learning.
So the key takeaways are behavioral as much as they are technical.
They are. Participants learn to adopt the mindset, to apply the framework flawlessly, and to communicate clearly under extreme pressure. It turns clinical uncertainty into systematic confidence.
So to synthesize all this.
The power of the CCrISP protocol is that it provides a time-tested structure that actively prevents the cognitive failures we're all prone to in a crisis.
Yeah.
The missed step, the fixation on the wrong diagnosis. When you integrate that with modern monitoring and timely senior help, it is. Well, it's arguably the single most important non-technical competency for modern surgical practice.
Which brings us to our final provocative thought for you. Given that our surgical patients are getting more complex, older, more comorbidities, consider this. How often do systematic frameworks like CCrISP prevent a patient from progressing to a catastrophic outcome, like needing dialysis or prolonged ventilation, before that failure ever even gets recorded on a formal audit?
It's the silent safety net we rely on every single day.
A very powerful thought.
And please remember, use this deep dive for professional reference only. In all clinical situations, you must always adhere to your established local clinical guidelines and protocols.
If you found this deep dive valuable, please don't forget to share it with at least one of your colleagues or friends. Help spread the word about systematic crisis management. And check out our YouTube and other social media pages for more curated knowledge. Thank you for listening.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.